So anyway, I just want to say that, you know, we also reached out to the communities here too, that we want to get some voice from.
I'd also like to piggyback on what Bob said. I think that really addresses that we would like for this group to help us identify where those gaps are. And what, we know there's going to be gaps in the data that we're going to have. And if this group could help us identify where geographically we need to collect more data, where populations that we're not addressing, where there's diversity. You know, we know the eastern side of Portage County is almost a whole different animal than the western side of Portage County. And that, you know, municipalities are on one side and the other side is very rural in its demographics. So, and those bring different challenges, both related to health needs and to access to health services. So, thinking about that, not so much that when we're looking at the data that we have, because I think Heather will tell you the limitations are, there are limitations to the data that we currently have. But knowing that this is going to be something that's going to go on beyond what we're looking at today, and that this is a process that won't stop, and that, you know, the next time around, we'll try to fill those gaps as we move forward. I think that's our intention anyway.
I got one thing to say, and this, and I'm going to relate back to Chip, what he was talking about as far as being unable to pass a levy to support the health departments. And it only, you know, for how many years, Chip? I don't even remember how long it's been.
It's over 55. We still haven't done a new levy, but we were able to replace it after 50.
Right. But it was done at the last election. And I think I can attribute some of that to healthcare awareness. I don't think, I mean, we made it very public at the association meetings and tried to promote it, but at least let everybody know what actually the public health system is and what it does for them. I think this is the key for everything that's going on here. I think they really need to know why it's there, what it does for them, and how it can help them in the near future. And because of that, I think this is the reason why we're standing here at this round table right now. It's just as simply because the people out there are now more aware of what it does and how it can help them. And I think that needs to continue even in a broader sense than where we're at right now. Publicity is the greatest thing in the world, especially if it's involving the awareness of this group. People really need to know that this group is coming together and what we're trying to do. I think that's really a key factor in succeeding in these goals that you laid down here. I'm off my soapbox now. I just thought I'd let you know, because actually involving with the task force, that was a key thing. We struggled a long time with that. It wasn't something that immediately happened, believe me. And due to everybody's efforts, and I think they're willing to join forces is how it ended up being as successful as it was. And I think this can do the same thing. It can only be successful if we're willing to join forces and look at the end results, that where we're trying to go and what's going to take to get there. And if we're all willing to pull together, I'm sure that can be done very easily. A large task is really a monumental thing, but when it's divided up into many, many segments, it can come together very quickly. I think this is where we can do.
I have a comment and a question. The comment is that we have a little bit of data from the mental health side, but I think the research term for it is crappy. It's terrible. It's terrible. It's embarrassing. Basically, because we don't have the time, the resources, and many times it's just, you know, it's word of mouth, asking things. But we do have 4 agencies within our board. We have them represented here today. And I guess the question is, do we envision, like maybe there is a questionnaire or a survey or something not just mental health and addiction things for our people, but we also, because many times, we may be the gatekeepers for people with health issues that nobody else knows, and vice versa. People come often for health care, physical health care. We've had some recent ones where people completed suicide after seeing their, under the hospital. They come back out and they haven't gone for mental health care, but they've seen a primary care person and so forth. There's other places that, we could gather some data as well for on both sides of the issue, mental health, drugs, as well as health. I don't know what that's the question is there. Because like through our agencies and so forth, we can poll our staff, they can poll their consumers, things like that. That's where we try to gather data, but it's done poorly and haphazard.
I don't know, Kelly was whispering in my ear that she thinks she understands your question/point, and I heard a little bit of both of them.
I didn't understand.
Well,
How are you gonna integrate your data into what we're looking at? Is that what you're asking?
Our data is, we'll share with everybody here, but it's very poor. I'm saying it up front, I'm embarrassed to even share it, because it's not, I can show you what we've done. It's poor. But I think going forward, sort of the end product, looking at this, are we having something, because it's like, we're not just doing this once, I think it's an ongoing
that's right.
assessment kind of thing. And what are the tools that we're actually going to use to collect that information?
And how can we be
All
part
right,
of that?
do you want to respond to this, Seth?
The process that we're trying to implement here, that we're trying to come up with, is to look at what data exists and feed off of that, because some priority health needs have already been identified in those assessments. However, logically, we know that there are health needs that exist outside of what data systems we can access, right? And so that's where this partnership comes in and says, what's missing? What's of importance? What needs to be added to this? And then you'll see down here in the findings, it's where are those future data collection and surveillance system needs, and what are our recommendations for that? So when you identify health needs, say, in the mental health area, in substance abuse area, and we look and say, we don't have data to support that, then we know that that is a piece that needs to be addressed going further. As well, there may be health needs where we have data that is crappy, right? And we're not real confident in what it's telling us, but yet we still feel as a collective that this is a health need of importance to our community. In which case then, we might put effort towards building that particular data system or strengthening it so that we do have more confidence in what the data is putting out. Does that make sense?
So what I hear is that what you really would like to see is better communication so that you can gather the data. For example, we don't receive a lot of hospital data on alcohol and drug pieces, or from the coroner's office. They have some things down as a suicide, it might be an overdose. And there's a lot of those differences in how we collect data. So one of the goals that I would see is how we can more effectively communicate with each other in order for all of us to get better data. So that, because a lot of times we're in a vacuum. We do our job and we go home, and every once in a while we run into somebody. But the truth is that somebody's viewpoint is based on their data and somebody else's viewpoint is based. If we could communicate the data together and actually look at it, you're going to have a big start on helping the community make priorities.
At our board meeting Tuesday night, the heroin epidemic came up that we're having right now. And one of the questions my board asked me was, well, what are you doing about drugs? And the answer is really nothing at this point, because back in 1980, when we did actually housed the drug and alcohol, we had a person in there, it was all grant related, but we had to give that up. And I know that you guys do that now. And I really feel that there's a commitment from especially my board and myself that when we get this data, or when we get this information from the community survey, where we have a lot of people out there saying that, then I think, we're definitely committed to being a point agency in this and trying to get the agencies together and people in this room to get some data and to get some help for this type of thing.
Chip, one of the things though that, and we'll, I don't wanna, get into a lot, one of the pieces is that we have a lot of services available for people with opiates. And
Yes.
my point is that we don't communicate to know what's the best way to make that referral. Or I have opiate users who really need medical help, and the federally qualified health center, we make referrals. The point is, I think it's even bigger than, oh, well, we need a specialist here and a specialist. We have so many services, we just need to be able to not duplicate them and put our money wisely into
Absolutely.
enhancement.
Absolutely, and that's what I'm talking
Yeah.
about, getting that together and putting it. And Becky knew right away, she's named a couple agencies right away that were dealing with that we could refer to the board. But it is a shame that at least the Portage County Public Health isn't more involved, and that I personally didn't know all the services that were available. But that's what you have for staff.
Yeah, you're right.
I just want to add a little to the conversation. It sounds like what everybody's talking about is something, a systematic process of, first you want to collect the data, identify the data that you have, and then what's missing, and then putting together a system in place in which you're collecting what you need, and then you can act upon the information that you have. I just wanted to add another cog to the wheel. Portage County is blessed with a number of institutions of higher learning, and we have access to a lot of students who are trained. I mean, between Kent and my program alone, they do data collection, they do data analysis. And so this is another piece where we have some manpower to be able to go into agencies and collect data systematically, use standardized survey instruments, and hopefully be able to collect data that will add to whatever we need here in Portage County.
Amy, we would love that, but we've been told how much it costs for somebody to come into our agency as a student, and we can't afford it.
What are the costs involved?
Oh, they're thousands of dollars to get an intern in public health and an intern in any data business collection right now.
We don't, they don't charge money to do it. And most of our students really, they don't.
We can afford
We don't
free.
charge any.
Yeah.
I mean, generally, a lot of these projects, and I'm sure Kent is the same, they have things called capstone projects or practicums or independent studies or whatever you call it.
In
We don't
all of the,
demand that
we
they
have lots and
be
lots of
paid.
interns in campus. We have all that. What we don't have is somebody on the technical side, business side. And those are where the costs, man, just, and that's the problem that we have. We can't do evaluation without spending $20,000 to evaluate a program. Or we can't get a really good set of data because we have to get somebody that isn't paid, and I mean, paid better than my counselor intern. So, I mean, seriously, it's a real issue. But I appreciate it.
Interject here. This is good dialogue. This is the kind of dialogue that I hope will unfold as a result of the process that we're going through. And I think, just comment on, I'll make two observations. One, I think Amy is correct. There are capacities at the institutions of higher education that can hopefully help in this process over time. The purpose of this group is to figure out what do we have and what can we believe. The discussion about kind of how to address it comes at a subsequent stage. But the point that Joel is making and Sue is making is that, there may be data here that isn't as good as we want it to be. And I guess I'll just encourage people, I don't think anybody needs to be embarrassed about their data right now. That would be my own judgment here. We got lots of data that's embarrassing around here, and
We'll give you some more.
if we start getting embarrassed about the data, we're not going to be doing what we need to do. What we need to do is look at the data, see what it tells us, rely on the judgments of people who have a knowledge base in this area, and decide where we need to collect more data. And it's at that point we can start having conversations about how best to get that done. But I do think Amy's point, underlying point, from sitting on the Kent side of the fence as opposed to the Neosmet side of the fence, there are ways, I think, in which the institutions of higher education, and Hiram as well, can potentially play a role in helping here. And I think that's a dialogue that will become a lot more productive if we do a good job on what's in front of us now.
But there needs to be some systematic organization around it. I think one of, the thoughts that many people have is that data just exists out there in space and we can always just grab it. It doesn't just exist out there, and good data particularly does not just exist out there. It requires some type of very systematic, coordinated effort, and I think that's why you are in the room. So let's identify what data needs to be collected, and we've got all the partners here to put together that systematic, coordinated effort to collect it, and I'll tell you, I'll analyze it. You collect it, I'll analyze it.
I want to pick up on something that Sue said. I wonder if we should invite the coroner to join this group, at least for a meeting or two. Sounds like, when we were thinking about what health providers we wanted, I must admit, did not think to include the coroner, and maybe we should do that.
They collect a lot of data.
They do, and we have an energetic new coroner who I think would be interested, so maybe we should make that connection.
Yeah, he just said, Wayne Enders from the coroner's office, we just came from a meeting of the Suicide Prevention Coalition, and they present both suicide statistics, drug overdoses, the deaths related to chronic alcohol use, and things like that. So that's real data. That's good stuff, but it really helps our coalitions.
And I suspect the sheriff's department has some of that.
Oh, yeah.
A lot of what we have, they have.
Was it? Yeah.
If I could just, I'm not an academia kind of person, but, and I understand when everybody's talking about collecting data and all that, and I understand all that, and I understand all the reasons behind it. My wife's PhD, and she's done all this in Summit County, so I've kind of heard that part of it during when she was going through it in Summit County. Going back to what Chip said, the whole heroin thing is something that we're dealing with on a regular basis, day to day, including today as I started my day off with another dead body. And I understand collecting data, but as we collect data, there's going to be a lot more dead people. And so I'm not sure where that falls or where we step up and say, what are we going to do for the community to heighten that awareness, to do whatever it is that, I had a long conversation with the guy who runs our drug task force, and he's been doing this job, he retired from another job before he started with us, so he's been doing this job for over 30 years. And he said he's never seen it as bad as it is today, and he's been doing it for 30 plus years. And we sit our office on a regular basis and say, what are we going to do? What can we do? And I think that's one of the reasons why the sheriff wanted me to be here, so that we could maybe help direct a little bit. I mean, I understand everything what everybody's saying, and I agree with it. But I think that somewhere along the way we've got to, parts of it have to be expedited, so that we can try to do whatever we can to make that body count smaller. I hate to put it that way, but I mean that's what we deal with every day. And we know, and it's not, it's across the county. It's no one area. It's across the county. And so there's just a part of me that just feels like all this is good. We need to do this. It's important to do it. There's also a piece of it out there because of the epidemic that we're calling it, and it is an epidemic. We've got to expedite something to try to get out to the community and let them know.
Well, we've had, something like 8 deaths in the last week?
Oh, yeah. That's
The deaths and heroin overdoses now they exceed traffic accident deaths.
Yep.
Not only in Portage County, but in the entire state. And it's a number of different reasons, but it's.
Dennis, it sounds like that almost calls for its own task force just to address that epidemic right now. Separate from this process, because this process is gonna go on and it's gonna take time. And that, you know, if it was an epidemic of a disease outbreak, the health department would be heading it up. Because we would try to stop it, you know, I mean,
There are
so,
big state efforts right now with opiates, with the alcohol drug folks. And I thank you, I'm with you on that.
You know, we just
instant command.
had a educational session, an all-day session on identifying methods. Because we have a lot of people in our health department that go door to door out doing different things and activities, and they may actually get to the door and open it, get smells and different things that we had a law enforcement person come in and do that seminar. This may be something, we're going to redo it again in the fall, and we opened it up to a lot of public officials, not just health department. And we had, and maybe we can add a heroin, maybe we can give it to you guys and see what we can do. I know it's not going to help anything right now, but it may be at least something that the health department would be willing to look at here in the fall when we have that session.
I know we'd be more than happy to work with you.
That'd be great. We can count on it.
Karen, did you have a comment? I do want to interject in response to the officer's comment, because I do think it gets at the issue that Mr. Mallory was talking about, and I think Dr. Baird addressed in her remark, and that is, it would be a mistake in my view, I will share this perspective from the standpoint of moving the process along, for us to allow our discussions to become a mechanism to create better and better data without understanding that 8 deaths in a week is evidence too. And it strikes me that as you all think about the criteria that we overviewed earlier, and this is a discussion for our next meeting, you know, one of the criteria is if you could have authoritative sources saying, you know, I'm coming across 8 dead bodies a week due to heroin, you know, we may not need much more data right now to call that a substantiated need.
That's exactly.
And so let's not, yeah, let's not get too worried about the intricacies there, would be the comment. Now that said, that may mean over time, you want to build a data system to be able to allow you to know whether you're making progress. And so, and that I think is what I heard Dr. Baird pointing to, that we need to take that, recognize that there's some evidence, recognize that it's imperfect evidence, but it may meet our threshold for this is a need. And then this report and future efforts could in fact refine, maybe geographically, maybe demographically. You know, there's all kinds of ways we can cut the data and collect the data to help evaluate whether progress is being made. And I guess the point I'm making is the process that we go through here, you all will have a lot to do with defining. That's what we hope to start accomplishing next week. But I don't think anybody should feel that you have to have huge ends, sample sizes, or flawless data that's ready to go in a peer-reviewed journal before a bunch of people who work in a field every day can decide persuasively that something is a need. And that's going to be where the judgment comes in. But I guess the point I'm trying to make is this group can influence that. We don't have to get lost in it.
Just on the follow-up on the other side of that though, I think that one of the things that most of us in this room have been service providers or have run programs or administered programs that are providing services to our community. And we've often jumped over the data and just went into providing the program because that's what we do. You know, we want to provide services to our community. And so we can't underestimate the value of when we look at this, we need to develop the process that we have a baseline to say that it's measurable, that we're going to be able to calculate that we're moving the barometer, because our community improvement plan is not going to be effective if we don't have a baseline to show that we're moving towards an increase or decrease, whatever that may be. And so we have to take the time. I know that sometimes that's painful for us who want to be the doers and want to be providing the services. And But yet I agree, we don't wanna be so lost in the minutia of the data that we don't move the process forward, so.
I think you're right, and I think maybe my hope as an optimist would be that everybody has their own strengths. So some people are really good at creating those evaluation measures in the planning process. Some people are really good at intervening, creating like the program itself.
And I think there's some easy solutions that we can construct in those places. I mean, if you have a substantiated need and you can write some evidence that's very believable and document that, then you've laid the foundation for what Kelly is talking about. We can have other people think through all of the particular metrics associated with it. But this group is here to identify the needs and establish the criteria for enabling those needs. And the next,
I think substantiated needs also perpetuate substantiating funds.
And they
Got
can't come without documentation.
That's right.
And that's where that whole thing that I was trying to say is, if I can't get somebody who's qualified to do that kind of data collection and evaluate, I can't get funds in order to increase drug and alcohol treatment.
Yeah, but now you don't have to do it alone.
I know, and that's why I just want to say, I'm so glad I'm here. I'm just saying, I'm so glad I'm here. But that is part of the issue as we go forward.
I think Dennis's point too, I mean, you have to have substantiation, or a lot of deaths come quickly like that where you get a lot of press, so you need data, press, or something that affects the legislator's family. Then we can
we are passing out what Amy mentioned a few moments ago, which is a timeline for our activities as we are seeing it. And we put rather specific information in this timeline. And so we wanted to share it with you and get feedback on it. At the top of the page, you'll see today, which is June 19th, the initial meeting of this partnership. Now, there's been some groundwork that has been done prior to this time that produced the pieces of paper we're sharing with you and some other things. But we're starting this timeline in terms of this group's activities. And as you can probably see from the second bullet, we're hoping to give you a little bit of homework already. Our hope is that you can start the perceptual side of this and send to us by the end of next week, a list of the 3 to 5 most important health needs in Portage County based on your perceptions as professionals in this field. And that information would be compiled and put together for use at our next meeting. We set dates, and we can have a discussion about these dates. We set dates approximately 2 weeks apart between now and the end of July, with the idea that at that point we would have been through much of the substance of the outline that we shared with you over meetings in July, with a copy of a draft report being developed between the end of July and mid to late August. And so what we would envision doing at our July 10th meeting at this point in time is having a discussion, which you all quite frankly have started now, about what are the criteria that we're going to use to mean that we have to have a substantiated need. And part of that might be, the officers in the sheriff's office have seen evidence that this is a real problem over a period of time that exceeds what they've seen in recent years. And that could be written up. Accompanying that evidence could be, I'm throwing these out as examples, could be we don't have good quantification of that data, so we need to look at developing a data system to monitor that more closely over time so that there can be baselines, so that there can be measures of effectiveness and improvement. We would envision that meeting on the 10th consisting of several main agenda items. Establishing at least a discussion around what the criteria will be, and we will come to you with a set of ideas, not conclusions, but ideas on what could constitute those criteria. We would envision at that meeting having Nishikant and Dr. Baird share with you the information that has come out of the assessments of capacity that have been done thus far, as well as the 3 needs assessments in summarized form at that stage, so that you can start understanding not only the needs that you've submitted to us, but also what the data is showing. And we'll start to look at those next to one another. In the meeting that would take place on the 24th of July, we would envision having a discussion around finalizing criteria for a substantiated need that would then inform the drafting of the report that would take place between the 24th of July and mid to late August. And this is going to be, it's going to be a rough draft report. It's not going to be perfect at that point, but that report in some form would then be discussed at a meeting at the end of August, collect your input, and produce a more refined report that would be used to guide the public engagement activity that Chip Porter mentioned a few moments ago, and that is a part of this process. That's the timetable that we had in mind generally. It's ambitious timetable, and we may find we need another meeting or two, and if that's the case, that's the case. But we do want to try to, we've got a fair amount of data there already. We've got people around the room who know this field. This is a dynamic process. We don't have to get it right once and for all forever. We need to get something in place that is documented and defensible, and then seek outside input and allow that to inform the community health improvement process that would move forward afterwards. So this is roughly what we've got in terms of timelines. We've actually set dates for the meetings. This was something we've learned because we have worked to facilitate a number of these meetings in the past, and we have found that if we try to find the date that everybody can be there, it's generally so far ahead in the future that you can't do it. And so we're suggesting these particular dates, but if everybody, if I don't know how many people we have in the room, it's probably on our list here, but if we have 20 people in the room and 19 of you can't make it on July 10th, then we need to know that now. But if 16 of you can, that's why we have the video, that's why we have email and phone, so that if you have to miss a meeting, you can weigh in another way. And so this is kind of what we had in mind time-wise. To the extent people want to probe, I'm happy to respond. Dr. Baird can respond. Maybe Josh can respond as well in terms of the thought processes in terms of what would be done at each of these meetings beyond what I've described. I'm going to look down. Amy, you raised the time frame issue. This is our stab at it at this point. Does this get where you were thinking when you have questions?
Absolutely, it's very aggressive.
It's very aggressive. And to be blunt, if we find that we have problems meeting it, we'll take another meeting if we have to. But I don't want the meetings to go too far. We got to make a cut at this and recognize